Imagine stepping into a neonatal intensive care unit. It is quiet. You mostly just hear the rhythmic hum of ventilators and the soft beeping of monitors.
Right, it is a very controlled environment.
Exactly. And in one of the incubators, there is a newborn baby, born premature, who starts to cry. So instinctually, the mother reaches in to cradle her child.
Which is, the most fundamental comfort a parent can provide.
It is. But the moment she lifts the baby, the moment she rocks them gently against her chest, that crying turns into agonizing screams.
Yeah, the very act of a mother's heart is literally causing physical torture.
In medicine, this terrifying phenomenon is called paradoxical irritability. And it happens because microscopic organisms have breached the blood-brain barrier.
They are quite literally consuming the sugar inside the baby's brain. It leaves the protective membrane so inflamed that the slightest movement is just pure agony.
It is one of the most harrowing clinical signs you could ever witness. Welcome to the Deep Dive. Today we are taking you on a massive mission to demystify one of the most complex and intimidating challenges in pediatric medicine.
We are talking about neonatal sepsis and neonatal meningitis. And, we like to think of a hospital as a sanctuary, but for a neonate, it is often a battlefield where the enemy is completely invisible.
So true. We are pulling from an extensive stack of medical literature today. Clinical guidelines, epidemiological data, rigorous diagnostic criteria. We really want to understand how the newborn immune system functions.
And how it fails, unfortunately. And how modern medicine acts as the ultimate bridge to survival when that system is entirely overrun.
We are not just going to skim the surface here. We are going to look at the microscopic warfare happening right in the bloodstream.
Right, examining the physiological mechanics of why a premature baby is so profoundly vulnerable, and the detective work required to diagnose a disease that constantly disguises itself.
Plus, the incredibly aggressive pharmacological interventions required to pull these infants back from the brink. But before we get to the battle strategies, we need to map the terrain.
We definitely have to understand the lexicon of infection first. Precision in language is the foundation of clinical medicine.
Yeah, because in casual conversation, people throw around words like bacteremia, septicemia, and sepsis as if they are interchangeable.
But in a NICU, those terms define incredibly specific physiological states. They are literally the difference between observation and an all-out medical code.
So let's establish the baseline for you. Neonatal sepsis, or NNS, is clinically defined as a syndrome.
Right, and a syndrome is a collection of signs and symptoms occurring together. Specifically, NNS is systemic signs of infection accompanied by bacteremia occurring within the first 28 days of life.
Systemic means the entire physiological network is reacting. It is not just a localized issue like a skin abscess or an infected umbilical stump.
The whole body is ringing the alarm, and the trigger for that alarm is the bacteremia.
Let's isolate that term. What exactly is bacteremia?
Bacteremia is simply the presence of viable, living bacteria in the blood. If you draw a sample of blood and identify bacteria in it, well, that is bacteremia.
Okay, but we have to aggressively contrast that with septicemia.
Right.
Absolutely. Septicemia is a systemic infection confirmed by the presence of actively multiplying bacteria in the blood.
I want to make sure the distinction here is crystal clear because it dictates the entire cascade of the illness. Let's think of the newborn's circulatory system, like the infrastructure of a massive city.
I like that analogy.
So bacteremia is like a small group of hostile actors crossing the city limits. They are there, which is a breach of security, but they might just be passing through.
Right. The immune system's border patrol might just round them up quickly.
But septicemia means those actors haven't just crossed the border. They have set up a syndicate. They are actively recruiting and establishing strongholds inside the city.
That is exactly the dynamic. Bacteremia is presence, but septicemia is proliferation. But then we hit the critical threshold, which is sepsis.
Following the city analogy, sepsis isn't just the presence of the syndicate. Sepsis is the city's own defense forces overreacting so violently that they start destroying their own infrastructure.
Yeah, the immune system launches this chaotic, overwhelming inflammatory response. And the resulting cytokine storm begins to severely damage the host's own tissues.
The defense mechanism essentially becomes the weapon of destruction. And if that destruction continues, we reach septic shock.
Which is defined as sepsis, coupled with cardiovascular organ dysfunction. The city's power grid fails. Blood pressure plummets because the blood vessels literally lose their tone.
They become leaky, right? And the heart cannot pump hard enough to compensate. So suddenly, the vital organs are starving for oxygen.
Which brings us to the clinical classification of severe sepsis. This is sepsis plus documented signs of end organ damage or hypoperfusion.
Hypoperfusion meaning inadequate blood flow. And the markers clinicians look for here are devastatingly specific in the literature.
They really are. They look at acute lung injury, which is measured as a low PaO2 to FiO2 ratio.
Let's unpack the mechanics behind that. You are pumping high concentrations of oxygen into the baby's lungs, the FiO2, but the actual oxygen making it into the arterial blood, the Pa2, remains dangerously low.
Exactly, because the inflammation has made the capillaries in the lungs so leaky that the air sacs are filling with fluid.
The baby is essentially drowning from the inside.
It is horrific. Another marker of end organ damage is an ileus. That is an absence of bowel sounds.
Because when blood pressure drops, the body performs ruthless triage. It shunts all available blood away from the gastrointestinal tract to try and save the brain and the heart.
Right. Without blood flow, the gut simply stops moving. It paralyzes itself. And the same triage affects the kidneys.
Leading to oliguria or a severe decrease in urine output. The kidneys aren't getting enough blood to filter, so they just shut down.
You also see increased total bilirubin, indicating the liver is failing to process waste. But the marker that really highlights the systemic chaos is thrombocytopenia.
A massive drop in platelets. Let's dig into that because platelets are what make our blood clot. Why do they suddenly vanish during severe sepsis?
It is a terrifying process called disseminated intravascular coagulation, or DIC. The bacterial toxins severely damage the endothelial lining of the blood vessels.
The inner walls of the vessels are damaged, and that widespread damage tricks the body into thinking it is bleeding everywhere all at once.
So it activates the entire coagulation cascade. It forms millions of microscopic blood clots throughout the circulatory system.
Wow, so this massive overreaction consumes almost all of the baby's available platelets.
Yes, they use up all their clotting factors, forming useless microclots. This leaves them completely vulnerable to catastrophic bleeding elsewhere.
It is a physiological nightmare.
Yeah.
And managing this nightmare in real time requires doctors to navigate a massive diagnostic gray area. The difference between proven and probable sepsis.
This is the operational reality of the NICU. Proven sepsis requires indisputable microbiological evidence.
Meaning you need a positive blood culture where you draw blood, incubate it, and actually grow the bacteria.
Yeah.
Or a positive PCR test identifying the bacterial DNA.
Alongside the clinical symptoms, yes, and the rules are incredibly strict here.
Like with coagulus-negative staphylococcal sepsis. That is a bacteria that naturally lives on human skin, right?
Right, so for that specific bug, you actually need 2 separate positive blood cultures. Or 1 positive culture plus an elevated inflammatory marker like C-reactive protein or CRP.
To officially call it proven. Because if the needle simply touches the baby's skin on the way into the vein, it picks up a harmless surface bacterium.
And that bacteria will grow in the lab. If you only have 1 culture, you might assume the baby has a roaring blood infection.
When in reality, it was just a contaminated needle. You need that secondary confirmation to prove it is a true pathogen.
But waiting for that proof is a luxury neonatologists simply do not have. Blood cultures can take 24, 48, sometimes 72 hours to yield a result.
And a premature baby in the early stages of septic shock will not survive a 48-hour wait.
Exactly, which is why the vast majority of initial treatment occurs under the classification of probable sepsis.
Meaning the clinical picture is deeply concerning. The baby is lethargic, temperature is unstable, blood counts are skewed, but the culture hasn't grown anything yet.
Or sometimes the culture never grows anything because the bacterial load in the tiny volume of blood drawn was just too small to detect.
Or the mother received antibiotics during labor, which stunned the bacteria enough to prevent them from growing in the petri dish.
Even though they are still wreaking havoc inside the baby. So you are forced to deploy your heaviest pharmacological artillery at the mere shadow of the enemy.
Now that we understand the gravity of these terms, we have to look at the scale of this threat. The epidemiological data reveals a global divide that is incredibly stark.
To appreciate where we are, you have to look at where we started. Before the discovery of antibiotics, the mortality rate for a neonate with a systemic blood infection was roughly 90%.
9 out of 10 babies simply did not survive. Today, modern medicine has wrestled that global average down to about 20 to 30%.
But an average is a mathematical smoothing that hides brutal geographic extremes.
Right. In highly resourced developed countries, the incidence of neonatal sepsis is relatively contained. about 1 to 4% of all live births.
But when you shift your gaze to developing nations, the numbers just explode. We're looking at incidences ranging from 49 to 170 cases per 1,000 live births.
The literature highlights specific local data from Nigeria that illustrates this crisis perfectly. The reported prevalence there ranges between 7.04 and 22.9 per 1,000 live births.
But the mortality rates hover consistently around 30%. The data specifically cites a 26.7% mortality in Abakaliki, 32.2% in Sagamu, and 33.3% in Isle Life.
Globally, neonatal sepsis accounts for 13% of all neonatal mortalities, and a staggering 42% of deaths in the very first week of life are driven by these infections.
It is the third leading cause of neonatal mortality overall. It sits right behind birth asphyxia and extreme prematurity.
But when I look at a 33.3% mortality rate in places like iLife, I have to ask, what is driving that specific lethality? The bacteria aren't inherently 30 times deadlier there than in New York.
No, the pathogens are largely the exact same. What you are seeing in that 33.3% is the lethal intersection of biology and infrastructure. Well, in a level 4 NICU, a baby with probable sepsis immediately receives continuous arterial blood pressure monitoring. They get titrated intravenous fluids delivered by precision micropumps to combat shock.
And rapid cycle laboratory testing every few hours.
Exactly. But in regions lacking that infrastructure or lacking a reliable cold chain to store specific broad-spectrum antibiotics, the window to reverse the cascade of septic shock simply closes.
The interventions just cannot be deployed in time. And there is a line in the epidemiological data that is perhaps the most chilling of all. It states many cases never reach treatment facilities, hence not reported.
Which means it is an absolute certainty that those massive numbers are an underestimation.
We just discussed rates of 170 per 1,000 and a 33% mortality. Are those official numbers just a vast underestimation of the real crisis?
Think about the logistics of rural healthcare in developing nations. If a baby is born at home, begins to show very subtle signs of lethargy on day 3,
Stops feeding on day 4.
and passes away on day 5 before the family can secure transport to a distant regional hospital, that death might simply be recorded as a generalized neonatal death.
If it is even officially recorded in a medical registry at all.
Exactly. The staggering statistics we have are largely just capturing the infants who were sick enough and fortunate enough to reach a facility where their blood could be drawn.
That invisible statistical shadow is immense. Now, you mentioned earlier that 42% of deaths occur in the first week of life. To understand why that specific 7-day window is the ultimate danger zone, we have to look at the timelines of infection.
The clinical literature segments neonatal sepsis into distinct chronological buckets: early onset, and very late onset.
And this chronology is not just for the sake of filing paperwork, right?
Not at all. The exact hour the symptoms appear tells the clinician almost definitively where the bacteria came from, which in turn dictates exactly which empirical antibiotics they must prescribe.
Let's break down early onset sepsis, or EOS. This is strictly defined as occurring within the first 72 hours of life.
The data indicates that these pathogens are almost exclusively acquired vertically, meaning from the maternal genital tract or the immediate delivery environment.
These are organisms the baby physically encounters on their journey out of the womb. The major culprits here are Group B streptococcus, or GBS E. coli, coagulus-negative staphylococcus, Haemophilus influenza, and Listeria monocytogenes.
Group B strep is the classic example here. Up to 30% of perfectly healthy adult women carry GBS in their gastrointestinal or genital tracts.
It causes the mother absolutely no harm. She doesn't even know it's there.
But when a neurologically and immunologically naive newborn inhales or swallows that bacteria during passage through the birth canal, it can rapidly colonize their lungs,
Causing a pneumonia that violently spills over into the bloodstream, triggering early onset sepsis.
It is an environmental mismatch. What is harmless flora to an adult is a lethal pathogen to a neonate.
Then we shift to late onset sepsis, or LOS, which presents after that 72-hour window. The clinical picture here changes dramatically.
The literature states LOS usually results from prolonged hospital stays and the necessity of invasive medical interventions. Things like central venous catheters and parenteral nutrition lines.
The pathogens shift from maternal bugs to things like Klebsiella, Serratia, Pseudomonas, Acinetobacter, and coagulase-negative staphylococci.
And briefly, they categorize very late onset sepsis as anything diagnosed between the 30th day and the day the baby is finally discharged from the hospital.
Look closely at the bacterial shift in late onset sepsis. We move from GBS to Pseudomonas and Acinetobacter. Think about the irony here.
It is the ultimate paradox of modern intensive care.
A hospital is an environment engineered with HEPA filters, ultraviolet light, and rigorous chemical sterilization to heal people. How does it become the primary vector for these incredibly dangerous late-onset infections?
To keep a 26-week premature infant alive, we have to systematically bypass every single one of their natural biological barriers.
Well, right, because they cannot coordinate sucking and swallowing, we thread a plastic tube down their esophagus.
Because their lungs lack surfactant and cannot stay open, we force a plastic endotracheal tube past their vocal cords.
And because their gut cannot digest milk, we thread a central venous catheter directly into a major vein sitting right above their heart to pump in liquid nutrition.
You are creating direct, open portals past the skin and mucosal defenses straight into the bloodstream.
And the bacteria that live in an NICU environment are entirely different beasts than the bacteria out in the community.
A hospital is constantly bombarded with powerful disinfectants and broad-spectrum antibiotics. The only bacteria that survive on the surfaces of a ventilator are the ones that have evolved extreme resilience.
They form thick, impenetrable biofilms.
Yeah, and they develop efflux pumps that literally spit antibiotics back out of their cells. So the life-saving medical interventions expose the baby to the most hardened, opportunistic, antibiotic-resistant bacteria on the planet.
The very tools keeping them alive are the vectors trying to kill them. This leads us directly to the core biological question. Why are newborns, and especially premature newborns, so exceptionally bad at fighting these bugs off?
The literature details a massive array of physiological vulnerabilities. It's fascinating to unpack just how unfinished a premature baby truly is.
I like that term, unfinished. It's not that their immune system is fundamentally broken, it's that they have been evicted from the sterile environment of the womb months before their biological software was fully coded.
And their hardware fully assembled. Let's look at the hardware first, the mechanical barriers. The epidermis, the skin of a preterm infant, is incredibly thin and easily bruised.
It lacks the hardened stratum corneum that we have, so the outer casing of our system is fragile. A simple piece of medical tape being removed can strip the skin and create a portal of entry.
And the internal mechanical barriers are just as compromised. They have critically low levels of protective secretions.
Things like mucus and tears, which physically trap and wash away infectious agents. Furthermore, the literature highlights poor ciliary action in the respiratory tract.
Coupled with an underdeveloped cough reflex. Cilia are those microscopic hair-like structures that sweep debris out of the lungs.
If a Pseudomonas bacterium lands in the airway of a preemie, there is no mucus to trap it, the cilia are too weak to sweep it up, and there is no cough reflex to forcefully eject it.
It just sits in the warm, moist lung tissue and begins to replicate.
But the physical hardware vulnerabilities are only half the story. The true deficit lies in the cellular immune response.
The antivirus software of the operating system.
Exactly. The literature goes deep into the specific cellular deficits, starting with the polymorphin nuclear leukocytes, specifically the neutrophils.
These are the frontline white blood cells whose entire job is to hunt down and eat bacteria, a process called phagocytosis.
The data notes that while a newborn might have an adequate number of neutrophils, their functional activity is severely deficient. Specifically, they have low chemotaxis and diminished adherence.
Let's translate that for you. Chemotaxis is the chemical GPS system of the immune response. When bacteria invade, they leave behind a trail of chemical breadcrumbs.
Injured tissue releases signal proteins.
Right. A mature neutrophil senses this gradient and actively crawls toward the highest concentration of the signal to find the infection.
But in a newborn, that chemotactic GPS is uncalibrated. The neutrophils wander around the bloodstream somewhat aimlessly, unable to efficiently locate the site of the breach.
And even if they blindly bump into a bacterium, the literature notes they have reduced opsonization ability.
Opsonization is the biological process of tagging the enemy. Most pathogenic bacteria are encapsulated, meaning they are slippery. The neutrophil tries to grab it, but it slips away.
Opsonization is when the immune system attaches specific proteins, like antibodies, to the surface of the bacteria, essentially giving the neutrophil handles to grab onto.
Because the premature baby hasn't had time to receive a full transfer of maternal antibodies across the placenta, which mostly happens in the final trimester, they lack these opsonizing tags.
The blind neutrophil bumps into the slippery bacterium and simply drops it. It's a cascading failure.
The data also points out low complement levels. The complement system is a complex cascade of proteins that circulate in the blood, and when activated, they assemble into a literal tube that punches a hole in the cell wall of a bacterium,
Causing it to explode. Preemies have very low levels of complement, making them highly susceptible to gram-negative bacterial infections.
They also have low levels of cytokines, like tumor necrosis factor, or TNF, and interferon. These are the chemical messengers that scream for backup.
And finally, poor monocyte macrophage function, meaning even if they do manage to engulf a bacterium, they struggle to generate the toxic oxygen radicals needed to actually digest and kill it inside the cell.
It is a profound, multi-layered immunological immaturity. But biology alone doesn't dictate the outcome. The clinical data strongly links these inherent vulnerabilities to specific maternal and environmental risk factors.
These factors act as the spark to this physiological tinderbox. The maternal risk factors are heavily tied to early onset sepsis.
The list includes intrapartum maternal pyrexia, which is a fever over 38.0 degrees Celsius, chorioamnionitis, a severe infection of the placental tissues, and amniotic fluid.
Malodorous liquor, meaning the amniotic fluid itself smells foul. A sustained fetal heart rate over 160 beats per minute, which is the baby's heart racing in distress.
Maternal urinary tract infections, GBS colonization, and the mother requiring parenteral antibiotics during labor. But the most prominent risk factor is PROM.
Premature rupture of membranes lasting greater than 18 hours.
Why is that 18-hour threshold so critical?
We have to remember that for 9 months, the fetus exists inside the amniotic sac, which is an impeccably sterile, clean room. The membranes are the physical walls of that room.
When a mother's water breaks, that protective bubble pops.
The physical barrier separating the sterile fetus from the heavily colonized vaginal tract is completely gone. If the baby is delivered within a few hours, the exposure is minimal.
But if 18 hours pass?
If 18 hours pass, you have given the ascending vaginal bacteria a day and a half to climb up into the warm, nutrient-rich incubator of the uterus.
They begin aggressively multiplying in whatever amniotic fluid remains.
And the fetus, naturally practicing breathing and swallowing movements, is continuously ingesting and inhaling this heavily infected fluid.
In the context of ruptured membranes, time is the ultimate enemy. Every passing hour exponentially increases the bacterial load the baby must face upon delivery.
Which makes the environmental and fetal risk factors entirely logical. Extreme prematurity and low birth weight mean the immune system is at its most unfinished.
Congenital malformations that physically break the skin barrier are massive red flags. The literature highlights meningomylocoe, a severe form of spina bifida where the spinal cord and nerves are exposed outside the body.
And gastroschisis, where the intestines protrude through a hole in the abdominal wall. If the structural integrity of the body is compromised from birth, bacteria have a VIP entrance straight into the systemic circulation.
Finally, the location of delivery is a major factor. Deliveries handled by traditional birth attendants, or those occurring on the road, in taxis, or in casualty wards, lack the sterile field.
They lack the chlorhexidine for umbilical cord care and the clean hands necessary to prevent immediate massive contamination.
So we have the pathogens, the broken barriers, the blind neutrophils, and the massive bacterial exposure. You would think, with an invasion of this magnitude, the disease would announce itself with deafening alarms.
But here is the most terrifying aspect of neonatal sepsis. It is a master of disguise.
This brings us to the clinical features and the incredible challenge of diagnosis. An adult with sepsis will violently shiver with rigors, run a raging 103-degree fever, and their heart will pound visibly against their chest.
They look profoundly, undeniably sick. But the literature describes the early clinical signs in a neonate as non-specific, non-localizing, and terrifyingly subtle.
A premature newborn simply does not have the metabolic energy reserves to mount a spectacular visible fight.
Their system doesn't roar, it just quietly starts to shut down.
The early signs listed are poor feeding, lethargy, poor activity, vomiting, respiratory distress, apnea and bradycardia, and temperature instability.
With the crucial caveat that their temperature can be high or low. Think about how agonizingly vague that is for a clinician.
Poor feeding and lethargy. A 48-hour-old baby is supposed to be sleepy. How do you distinguish between a baby who is just exhausted from the trauma of birth and a baby whose central nervous system is being suppressed by circulating bacterial endotoxins?
It is the ultimate clinical needle in a haystack. Take temperature instability. The hypothalamus, the brain's thermostat, is immature in a preemie. They lack insulating body fat.
They can drop their temperature just because the incubator door was open too long during a diaper change.
So is the low temperature an environmental artifact, or is it the primary indicator that they are sliding into cold septic shock?
You have to look past the generic signs to the specific markers of poor perfusion. The data highlights a capillary refill time, or CRT, greater than 3 seconds, modeling of the skin, and hypotension.
But the most fascinating physiological clue listed is a toe core temperature gap of greater than 2 degrees Celsius. This is a brilliant, entirely objective indicator of shock. Core temperature is the heat of the vital organs, the brain, heart, and liver, usually measured via a rectal or deep axillary thermometer.
And toe temperature is peripheral. It's the extreme end of the circulatory line.
Right. When a baby enters the early stages of shock, the autonomic nervous system realizes there isn't enough blood pressure or oxygen to sustain the whole body. So it executes a ruthless physiological triage.
It decides what is expendable.
Precisely. It aggressively clamps down on the peripheral blood vessels leading to the skin, the arms, and the legs. It sacrifices the extremities to shunt all remaining warm, oxygenated blood to the brain and the heart.
So the core temperature might read a perfectly normal 37 degrees Celsius. But if you place a probe on the baby's toe, it might read 34 degrees.
That gap of more than 2 degrees is the body actively screaming that it is rationing blood flow to survive. The foundation is cracking, even if the baby otherwise appears quiet.
And because these signs are so subtle and so heavily tied to generalized physiological failure, neonatal sepsis mimics almost every other major complication a newborn can experience.
The differential diagnoses, the list of things it could be, is dizzying. Let's look at how sepsis disguises itself.
Under respiratory mimics, we have respiratory distress syndrome, or RDS, aspiration pneumonia, and transient tachypnea of the newborn, TTN.
If a preemie is grunting and flaring their nostrils, how do you know if it's because their immature lungs lack surfactant, which is RDS, or because an E. coli pneumonia is destroying the lung tissue?
In the first 12 hours, clinically, you often cannot tell the difference. The presentation is identical.
Under neurologic mimics, the data lists hypoxic ischemic encephalopathy, or HIE, which is brain damage from lack of oxygen during birth.
Also neonatal seizures and intracranial hemorrhage. A baby who is lethargic and twitching might have a brain bleed from fragile premature blood vessels, or they might have an active meningeal infection.
Cardiovascular and digestive mimics are just as complex. Congenital heart defects, like a closing ductus arteriosus, can suddenly throw a baby into cardiogenic shock that looks exactly like septic shock.
Necrotizing enterocolitis, or NEC, where the gut tissue begins to die, or spontaneous GI perforations present with a distended, painful belly.
Is the gut failing because of poor perfusion from sepsis, or is it a primary surgical emergency? Even the metabolic and hematologic mimics are identical.
Right. The literature lists hypoglycemia, low blood sugar, inborn errors of metabolism like organic acidurias, vitamin K deficiency bleeding, and immune-mediated thrombocytopenia.
And hemolytic disorders like ABO or RH incompatibility.
But the most striking one here is congenital adrenal hyperplasia, or CAH. This is a genetic condition where the baby lacks the enzyme to produce cortisol and aldosterone.
Without those hormones, their kidneys waste salt, they hold on to potassium, and their blood pressure absolutely crashes. A baby in a CAH adrenal crisis looks physiologically identical to a baby in gram-negative septic shock.
Which is why neonatology requires absolute diagnostic discipline. You cannot rely on your eyes alone. A mottled lethargic baby with low blood pressure could have an infected bloodstream, a broken heart, a bleeding brain, or a missing adrenal enzyme.
To find the truth, you have to look at the blood itself.
The detective work relies on hard laboratory criteria. The clinical guidelines outline the specifics of the full blood count, the FBC, in exhaustive detail.
And interpreting an FBC in a neonate is wildly different than in an adult. Let's look at the white blood cell count.
The data states that findings suggestive of sepsis include a WBC decrease below 5,000 per cubic millimeter, or R increased above 34,000 per cubic millimeter.
It also zeroes in on the absolute neutrophil count, citing concern if it is less than 2 or greater than 15 times 10 to the 9th per liter. Platelets under 100 are also a red flag.
Let's pause on the WBC paradox. Because, wait, the white blood cells can be too low or too high. The temperature can be too low or too high. How do clinicians find confidence in a system built on such extremes?
The paradox actually reveals the exact state of the battle. White blood cells, specifically neutrophils, are the infantry. If a baby is invaded by bacteria, the bone marrow, the weapons factory, detects the cytokine alarm and radically ramps up production.
It pumps massive amounts of new white blood cells into the circulation to fight the infection.
Therefore, a wildly high WBC count, over 34,000, tells you the immune system is actively mobilizing a massive defense. The fight is on.
Okay, more infection equals more troops. That is intuitive. But why does a count below 5,000 also indicate severe infection?
This goes back to the concept of the unfinished immune system. A premature baby's bone marrow has an incredibly small reserve storage pool of mature neutrophils.
When a massive bacterial invasion occurs, the marrow dumps every single available cell into the bloodstream.
But the bacteria are proliferating exponentially, and
Yeah.
the neutrophils are dying by the millions as they attempt to phagocytize the invaders. The bone marrow simply cannot manufacture new cells fast enough to replace the casualties.
So the storage pool is completely emptied. The low count isn't because the body doesn't know there is an infection. It's because the body has literally run out of ammunition.
Exactly. We call it leukopenia. A very high WBC count means the baby is sick, but their body is fighting. A critically low WBC count, under 5,000, is far more ominous.
It means the immune system has suffered complete physiological exhaustion. The bone marrow is empty, and the bacteria are overrunning the system unchecked.
That makes terrifying sense. And the diagnostic criteria dig even deeper into the specific quality of these neutrophils. They don't just count the soldiers, they inspect their uniforms.
The literature highlights toxic granulation in neutrophils. What exactly is that?
When the bone marrow is in a state of absolute panic, desperately rushing to push out neutrophils to fight a severe systemic infection, the normal cellular maturation process breaks down.
Toxic granulations are heavy, dark, coarse granules that appear inside the cytoplasm of the neutrophil when viewed under a microscope.
They're essentially abnormal lysosomes filled with bactericidal enzymes. It is the microscopic equivalent of a soldier being shoved onto the battlefield half-dressed, carrying unstable, highly volatile munitions because the factory didn't have time to finish the assembly process.
Wow, so it is a definitive marker of severe inflammatory stress. The panic in the bone marrow also leads to what the data calls a left shift.
The criteria highlight an immature to total neutrophil ratio, the IT ratio, of greater than 0.2, and a Bands to total neutrophil count ratio greater than 0.2.
A band cell is an immature neutrophil, right? It hasn't fully developed its segmented nucleus yet.
Correct. Under normal conditions, the bone marrow only releases fully trained, mature, segmented neutrophils into the blood. But in the desperation of sepsis, the marrow starts drafting the reserves.
It pushes out immature teenage band cells. If more than 20% of the circulating neutrophils are immature, you know the bone marrow is scraping the absolute bottom of the barrel.
Which is why clinicians rely so heavily on a specific mathematical calculation provided in the guidelines, the absolute neutrophil count, or ANC.
An ANC of less than 1,000 per cubic millimeter is considered a massive red flag for severe neutropenia and high mortality risk. The guidelines actually map out the math for you.
If the total WBC count is 8,000, and the differential shows that 50% of those white blood cells are neutrophils, you multiply 8,000 by 0.50 to get an ANC of 4,000.
That seems fine. But if I apply the logic of the exhausted bone marrow we just discussed, if that total WBC count crashes down to 1,500, even if the percentage of neutrophils remains exactly the same at 50%, 50% of 1,500 is only an ANC of 750.
Exactly. You have hit on the exact reason the math is necessary. The percentage is an illusion of safety.
50% sounds like a balanced, normal differential. But the absolute number reveals that there are only 750 functional soldiers left in the entire circulatory volume.
The baby is profoundly neutropenic and virtually defenseless, regardless of the reassuring percentage. The ANC strips away the ratios and gives the clinician the unvarnished truth of the baby's remaining defensive capability.
Alongside this complex FBC analysis, the guidelines mandate aggressive culturing. Blood cultures are the gold standard, but urine cultures are obtained, particularly in late-onset cases.
As well as culturing fluid from intravenous lines or catheters, though the literature notes the yield from plastic lines may be small. Chest radiographs are utilized if there are respiratory signs to rule out that RDS or aspiration we discussed.
The doctors are essentially building a massive circumstantial case. The toxic granulations, the crashing ANC, the IT ratio. They need to justify immediate treatment while they wait the 48 hours for the blood culture to definitively grow the bacteria.
Because what happens when the bacteria don't stay confined to the bloodstream? What happens when the exhausted bone marrow and the plunging ANC allow the bacteria to seek out higher value targets?
They seek out the most nutrient-rich, vital real estate in the human body. They target the central nervous system.
This is the brain breach, neonatal meningitis. The clinical literature states that in approximately 15% of neonates who develop sepsis, the infection breaches the ultimate fortress.
The meninges, the protective membranes surrounding the brain and spinal cord. The blood-brain barrier is a highly selective, tightly woven matrix of endothelial cells designed to be absolutely impenetrable to pathogens.
But the systemic inflammation of sepsis, that cytokine storm, causes those tight junctions to loosen. The barrier becomes leaky, allowing circulating bacteria to cross over into the cerebrospinal fluid, or CSF.
The etiology listed mirrors sepsis, noting that the risk of meningitis increases directly with high colony counts in the blood.
Meaning the more bacteria multiplying in the bloodstream, the harder they batter against the blood-brain barrier until it gives way.
The primary pathogens are group B streptococcus, predominantly type 3, which has a specific affinity for the meninges, also E. coli and Listeria monocytogenes.
The data also reemphasizes that central nervous system anomalies, like spina bifida, drastically increase risk because they represent a literal physical highway bypassing the blood-brain barrier entirely.
If the skin and bone over the spinal cord are open to the air, the bacteria don't need to batter down the blood-brain barrier. They just walk right into the subarachnoid space.
The clinical features of meningitis include all the subtle signs of sepsis, plus signs of central nervous system irritation, but the literature provides a crucial warning to clinicians.
The classic signs of meningitis taught in medical school rarely apply to premature newborns. It notes that a bulging or full fontanelle, the soft spot on the top of the skull expanding from the pressure of infected fluid, only occurs in about 25% of cases.
Neutral rigidity, or a stiff neck, occurs in a mere 15%. They may present with cranial nerve abnormalities, specifically palsies of the 3rd, 6th, and 7th nerves.
This is a critical diagnostic trap, right?
Absolutely. In an older child or adult, severe inflammation of the meninges causes the neck muscles to violently spasm and lock up. That is neutral rigidity.
But a premature infant simply does not possess the muscle mass or the neurological tone to mount that kind of rigid defense.
If a physician waits for a preemie to develop a stiff neck before suspecting meningitis, they will miss the diagnosis entirely until it is far too late.
They have to look for the microscopic signs, like an asymmetrical facial grimace indicating a 7th cranial nerve palsy, or an eye that fails to track properly indicating a 3rd or 6th nerve issue.
And they have to watch for paradoxical irritability, which we had talked about at the very beginning of our deep dive. The pain of the inflamed meninges shifting against the brain when the baby is rocked or cuddled.
To confirm this devastating breach, doctors must perform a lumbar puncture, inserting a needle into the lower spine to draw out and analyze the cerebrospinal fluid.
The diagnostic thresholds provided in the literature are fascinating because they paint a vivid picture of the microscopic war.
The CSF analysis is the definitive window into the brain's environment. Let's look at the white blood cells in the CSF first.
In a normal, healthy term or preterm infant, the WBC count in the spinal fluid is very low, less than or equal to 20 cells per microliter.
But in meningitis, the criteria note an increase of 20 to 30 cells per cubic millimeter. This makes sense. The immune system realizes the brain is under attack and sends white blood cells across the barrier into the CSF to fight.
Next is protein. Normal CSF protein is less than 100 mg/dL in term infants and up to 150 mg/dL in preterms. In meningitis, the protein levels spike dramatically.
Why does the fluid suddenly become so protein-heavy?
2 intersecting reasons. First, the invading bacteria themselves and the thousands of white blood cells rushing in to fight them are physically made of protein. More cellular mass in the fluid means a higher protein concentration.
That makes sense.
Second, remember that the inflammation makes the blood-brain barrier leaky. Large protein molecules circulating in the blood, which are normally far too big to pass through the barrier's filter, are suddenly able to spill freely into the spinal fluid.
But the most illustrative metric is glucose. Normal CSF glucose is maintained at a level greater than 75% of the serum blood glucose measured at the exact same time.
But in meningitis, the criteria show the glucose dropping precipitously, crashing below 20 mg/dL in preterms and below 30 mg/dL in term infants.
We mentioned earlier the bacteria are eating the sugar. Let's expand on that.
Yeah.
The brain is the most metabolically demanding organ in the body, and it runs almost exclusively on glucose provided by the CSF.
Precisely. The spinal fluid is designed to be a continuous, nutrient-rich delivery system for the brain tissue.
But bacteria are living organisms with massive energy requirements, especially when they are rapidly multiplying.
Through a process called glycolysis, the invading bacteria aggressively consume the glucose in the spinal fluid to fuel their own replication. They are literally outcompeting the brain tissue for its own food source.
A crashing CSF glucose level is absolute proof that a massive colony of bacteria is actively feeding inside the central nervous system. The bacteria are starving the brain to build their army. It is a horrifying mechanism.
The diagnostic guidelines also note that if the CSF cultures are negative, perhaps because the baby received a dose of antibiotics prior to the lumbar puncture, clinicians should utilize multiplex PCR panels.
These panels can detect the exact DNA signatures of multiple common pathogens directly in the fluid. They also rely on ultrasound, CT, or MRI imaging to look for structural complications.
And those complications lead us to the prognosis, which is incredibly grim. The central nervous system does not tolerate inflammation well.
The data states that without treatment, the mortality rate for neonatal bacterial meningitis approaches 100%. It is a universally fatal disease if left to run its course.
With aggressive treatment, the mortality drops to 5 to 20%. However, for organisms that cause necrotizing meningitis, where the bacteria actually cause vasculitis and brain abscesses, literally destroying the brain tissue, the mortality can approach 75% even with treatment.
And the collateral damage is immense. Of the survivors, 20 to 50% face severe, lifelong neurologic complications. This includes hydrocephalus, which is a dangerous buildup of fluid deep within the brain cavities.
Permanent hearing loss and intellectual disability. The inflammatory war zone inside the skull rarely leaves the delicate architecture of the developing brain completely unscathed.
The high stakes of this prognosis are exactly why the treatment protocols we use are so intense, so immediate, and so unrelenting. Which brings us to the counterattack, fighting back.
We know the exact nature of the blood and brain infections, the crashing neutrophils, the starving brain. How do clinicians deploy their pharmaceutical arsenal to save the infant?
The clinical guidelines detail incredibly specific treatment protocols and supportive therapies. The cornerstone of the initial response is empiric therapy for sepsis.
Empiric is the key word here. It means treating based on clinical experience, epidemiological data, and statistical probability, long before you have the definitive culture results.
Because, as we established, you cannot wait 48 hours for a lab result when the baby's absolute neutrophil count is 500 and their core-to-toe temperature gap is widening.
The guidelines state empiric broad-spectrum therapy must be initiated immediately upon suspicion. The most common frontline approach is a combination of ampicillin and gentamicin, or the use of second and third generation cephalosporins.
If the infection is suspected to be nosocomial, hospital-acquired late-onset sepsis, they bring out the heavy hitters immediately, utilizing vancomycin or fluoroquinolones combined with ambicacin.
Let's look at why ampicillin and gentamicin are the classic pairing. They work synergistically.
Ampicillin is a beta-lactam antibiotic. Its job is to attack and inhibit the synthesis of the bacterial cell wall, which is highly effective against gram-positive bugs like group B strep.
Gentamicin is an aminoglycoside. It works by entering the bacteria and binding to their ribosomes, completely shutting down their ability to synthesize proteins, which is lethal to gram-negative bugs like E. coli.
When used together, the ampicillin punches holes in the bacterial cell wall, which allows the gentamicin to flood inside and destroy the internal machinery. That is a brilliant biochemical 1-2 punch.
But the protocols also include a crucial rigid off-ramp. The empiric antibiotics must be stopped at 48 hours if the blood cultures remain negative and the baby appears clinically well.
I want to look at the tension here regarding antibiotic stewardship. We are constantly warned by public health officials about the dangers of creating antibiotic-resistant superbugs by overprescribing broad-spectrum antibiotics.
It is a massive concern. Broad-spectrum antibiotics do not discriminate.
They wipe out the pathogenic bacteria, but they also decimate the baby's fragile, developing, healthy gut microbiome. And yes, overusing them drives resistance.
Neonatologists agonize over this balance every single day. But you are balancing the hypothetical future risk of global antibiotic resistance against the immediate lethal mathematics of a neonate in shock.
A newborn can deteriorate from appearing mildly lethargic to full cardiovascular collapse in a matter of hours. If you withhold antibiotics for 24 hours waiting for a lab test, that specific patient will likely die.
The protocol mandates that you shoot first to save the life in front of you, covering the most likely killers, and ask questions later. And the 48-hour stop rule is the compromise.
Once the culture comes back, if it identifies a specific bug, you immediately narrow the drug profile to target just that bug. You de-escalate.
And if the cultures are clean at 48 hours and the baby is stable, you stop the drugs entirely. You do not finish a 7-day course just to be safe. You stop minimizing the ecological damage to the baby's microbiome.
That makes the reality of the NICU floor very clear. Now let's look at the specific protocols for meningitis. The stakes are localized to the brain, so the drugs must change.
The empiric regimen here is ampicillin plus gentamicin AD, a third-generation cephalosporin, specifically cefotaxime. The ampicillin covers the GBS and listeria. The gentamicin provides synergy.
But why add the cefotaxime?
It comes down to pharmacokinetics, specifically blood-brain barrier penetration. Many powerful antibiotics that work beautifully in the bloodstream are simply too large or chemically incompatible to cross over into the spinal
Could
fluids.
bounce right off the barrier.
Cefotaxime, a third-generation cephalosporin, is specifically chosen because it crosses the inflamed meninges exceptionally well, delivering a massive bactericidal payload directly into the CSF where the bacteria are feeding.
The guidelines include a very stark warning regarding gram-negative bacillary meningitis. It explicitly states that relying on the traditional regimen of ampicillin plus an aminoglycoside results in an unacceptable 15 to 20% mortality rate with a high rate of severe sequelae.
Therefore, cefotaxime must be used. And if antibiotic resistance is a major concern, say a hospital-acquired Klebsiella infection in the brain, they escalate to extended-spectrum beta-lactams, like meropenem, until the specific sensitivities are known.
They also include a fascinating hardline rule. Corticosteroids are not used in neonatal meningitis. In adult medicine, giving steroids during meningitis is a common tactic to reduce the massive brain swelling and prevent hearing loss. Why are they strictly banned for newborns?
It is a matter of immunological capacity. In an adult or older child with Haemophilus influenza meningitis, their immune system is robust. Giving a steroid like dexamethasone right before the antibiotics blunts the explosive inflammatory response as the bacteria die, which saves the delicate hair cells in the ear.
But a neonate's immune system, as we discussed with the crashing ANC, is already barely functioning. If you give a powerful immunosuppressant like a corticosteroid to a premature infant to reduce swelling, you risk turning off their immune system entirely.
You essentially open the gates and allow the bacteria to multiply completely unchecked. Furthermore, high-dose steroids in preemies are strongly linked to severe long-term neurodevelopmental impairment. The risks far outweigh any theoretical benefit.
So no steroids. The duration of this chemical warfare is also staggering. The protocols dictate that parenteral or IV therapy for gram-positive meningitis must be given for a minimum of 14 days.
For complicated gram-positive or gram-negative meningitis, it is a minimum of 21 days. 3 solid weeks of continuous intravenous antibiotics.
Because the architecture of the brain and the meninges contains countless microscopic crevices where bacteria can hide. If you stop at 10 days, a tiny colony might survive, and the infection will roar back with a vengeance.
The long duration ensures absolute eradication. And while the antibiotics are fighting the bacteria, the medical team is fighting to keep the baby's physical infrastructure from collapsing.
The supportive therapy guidelines are extensive. They must continuously correct anemia, electrolyte imbalances, and acid-base derangements in the blood. They meticulously prevent hypoxia and hypoglycemia, ensuring the brain always has fuel.
They maintain a strict thermoneutral environment so the baby doesn't waste precious metabolic energy trying to stay warm. But the most extreme interventions listed involve the blood itself.
Exchange blood transfusion, or EBT, and buffy coat transfusions. What is an exchange blood transfusion actually doing?
It is exactly what it sounds like. In profound septic shock, the baby's blood is heavily saturated with bacterial endotoxins, inflammatory cytokines tearing the vasculature apart, and their bone marrow is completely exhausted.
In an EBT, clinicians slowly withdraw the baby's toxic, depleted blood in small increments while simultaneously infusing fresh, fully functional donor blood.
You are physically removing the poisons and the bacteria while instantly replacing their exhausted neutrophils and consumed platelets with a fresh, mature defense force.
It is literally swapping out the battlefield. They also list immunoglobulins for severe infection. This goes back to the opsonization deficit we discussed. They are intravenously providing the antibody tags so the baby's remaining neutrophils can finally grab onto the slippery bacteria.
And treatment with recombinant cytokines, essentially injecting synthetic chemical messengers to try and jumpstart the baby's cellular communication network. It is a massive, multi-front war of attrition.
Which highlights a profound truth. When you look at the grueling nature of these treatments, the immense cost, and the terrifyingly high risks of mortality and lifelong neurological disability, it becomes obvious that the ultimate goal cannot just be treatment.
The goal must be to ensure the pathogens never breach the fortress in the first place.
Which carries us to the final and perhaps most vital aspect of our deep dive, the shield. Prevention strategies. The literature outlines a series of preventative measures, and what is truly striking is the sheer contrast between the high-tech, aggressive interventions we just spent 20 minutes dissecting, and the incredibly low-tech nature of the prevention.
The most powerful medicine is often rooted in the most fundamental biology.
The list starts with comprehensive antenatal care, minimizing maternal risk factors to avoid preterm, low birth weight, and asphyxiated deliveries altogether. Then it focuses on the environment.
Regular, rigorous hand washing to reduce contamination of the baby's fragile skin and mucosa. Sepsis control protocols in newborn units, which means strictly reducing traffic flow and personalizing facilities.
Ensuring babies are not sharing stethoscopes or equipment that could pass Pseudomonas from one incubator to the next. But the final 2 points are the most profound. Early and exclusive breastfeeding and delivering the baby directly onto the mother's abdomen for skin-to-skin contact for the critical 1 hour immediately after birth.
It is amazing.
I have to marvel at this. We just unpacked the biochemical synergy of ampicillin and gentamicin, the blood-brain barrier penetration of cefotaxime, and the logistics of an exchanged blood transfusion. Yet the primary defenses, the shields that prevent all of that from ever being necessary, are essentially soap, mother's milk, and physical hugs.
It sounds poetic, but the mechanisms behind it are deeply, rigorously scientific. Let's look at that critical 1 hour of skin-to-skin contact. It is not just about emotional bonding or temperature regulation. It is an active, highly effective immunological intervention.
We established earlier that the baby is born essentially sterile and immediately encounters a world of bacteria. If a baby is taken away from the mother, placed on a warmer across the room, and handled by multiple staff members, the very first bacteria that colonize its pristine skin and gut are hospital-acquired pathogens.
The hardened, antibiotic-resistant bugs that cause late-onset sepsis.
Right, the bugs that form biofilms and spit out antibiotics.
Exactly. But if the baby is placed bare-skinned directly onto the mother's bare chest the second they are born, the baby is instantly inoculated with the mother's microbiome. The healthy, safe community bacteria that live harmoniously on her skin migrate directly onto the baby.
These safe bacteria physically take up all the available real estate on the baby's skin and begin colonizing their gut. They aggressively crowd out the dangerous hospital pathogens.
It is a biological principle called competitive exclusion. That physical hug is literally armoring the baby in a microscopic living shield of safe bacteria.
And the breast milk compounds that defense. Early and exclusive breastfeeding isn't just about calories. Breast milk is packed with maternal antibodies, secretory IgA, which coats the gut lining to prevent bacterial adherence, and heavy concentrations of lactoferrin.
Lactoferrin is a protein that binds tightly to iron. Since bacteria require free iron to multiply, lactoferrin effectively starves any pathogens in the gut before they can cross into the bloodstream.
The mother's body is providing both the blueprint and the physical materials to finish the construction of the baby's immune system in real time. In regions where you lack the infrastructure for multiplex PCR panels, meropenem infusions, and mechanical ventilators, exclusive breastfeeding and rigorous hand hygiene are undeniably the most powerful, life-saving tools in human existence.
It is a stunning realization.
As we wrap up this extensive journey, let's briefly look back at the ground we've covered. We started with the vital precision of our lexicon, tracking the escalation from a simple bacteremia crossing the borders to the systemic self-destructive chaos of severe sepsis and DIC.
We examine the stark epidemiological divide, where a lack of infrastructure turns an infection into a 33% mortality rate in places like Life.
We categorize the invaders, distinguishing the vertically transmitted GBS of the first 72 hours from the hardened, opportunistic, hospital-acquired pathogens of late-onset sepsis. We mapped every vulnerability of the newborn's unfinished operating system, from the thin epidermis to the blind neutrophils lacking their opsonization tags, and saw how maternal risks, like a prolonged rupture of membranes, ignite that vulnerability.
We explored the chameleon-like clinical presentation, where a sleepy baby with a widening toe-core temperature gap might actually be in shock, or might be mimicking it through a congenital heart defect or an adrenal crisis.
We watched doctors rely on the complex mathematics of the absolute neutrophil count and the presence of toxic granulations to prove a diagnosis before the cultures could grow. We witnessed the devastating breach of the blood-brain barrier in meningitis, where bacteria literally consume the brain's glucose, causing the tragic paradoxical irritability.
And finally, we covered the aggressive, synergistic antibiotic warfare required to fight back, beautifully balanced against the evolutionary perfection of skin-to-skin prevention.
It is an incredible spectrum of medical science. We have traversed from macroscopic global public health data down to the microscopic battles happening inside a single microliter of cerebrospinal fluid.
It truly is.
But as we close, there is one final, deeply provocative thought hidden in the clinical guidelines that I want to leave you, the listener, to mull over. When discussing the diagnostic criteria for meningitis, the literature specifically states that normal CSF values do not exclude a diagnosis of meningitis.
It notes that bacterial meningitis has actually been identified by culture in neonates, who had completely normal white blood cell counts and perfectly normal glucose levels in their spinal fluid.
Because the traditional metrics can sometimes lag behind the infection, medicine is increasingly turning to those multiplex PCR panels we mentioned, technology that amplifies and detects the absolute tiniest, most microscopic fragments of bacterial DNA.
The sensitivity of our diagnostic tools is increasing at an exponential, almost unimaginable rate.
Exactly. That leads to a fascinating philosophical and medical question. As our molecular technology becomes hypersensitive, capable of detecting mere fragments of DNA that aren't even actively causing an inflammatory response yet, will we eventually reach a point where we have to fundamentally redefine what an infection even is?
If we look closely enough with a powerful enough PCR panel, are any of us, even a newborn in the very first hour of life, truly biologically sterile?
Where exactly do we draw the line between a harmless microscopic passenger and a deadly systemic threat, when our tools can suddenly see every single passenger in the vehicle?
That is the absolute frontier of infectious disease, finding the true pathological signal in an increasingly microscopic, infinitely complex sea of genetic noise.
It brings us right back to the tension we started with. We constantly crave the undeniable clarity of the X-ray. We want a clean, jagged white line. We want the mere presence of DNA to definitively mean infected and the absence to mean safe.
But human biology, especially a newborn body in the chaotic transition of birth, refuses to be boxed up that neatly.
The diagnostic landscape remains muddy, but the dedication to navigating those waters, to understanding the mechanisms, finding the truth, and saving the child, is nothing short of extraordinary. Thank you for joining us on this deep dive. Stay curious, keep exploring the mechanisms behind the medicine, and we'll see you next time.